Vollenweider, I think he doesn't need any introduction. I would just say, besides the research, I saw a movie from you, Last Insight, Descending the Mountain, and this was bringing research outside to the Buddhist monastery, and that was great. So I'm looking forward to your talk, which would be on the topic of mapping the neurobehavioral space. Thank you very much.
Good morning. I'm pleasure to give you a talk and to be back to Berlin to this conference. Today, I do not want to go too much into technical details. I rather want to show up some problems we have with looking into markers or measures of biological measures of psychedelic states, or how we can link them to the acute experience and to symptom reduction. Now, my home is the University Hospital of Zurich, where we started with LSD in 1948. Conrad did the first study into depression at that time. And when I came in 92, I was very interested in trying to get biological markers or biological techniques or neurocognitive techniques to approach what's going on with psychedelic. And there was a long tradition by Dietrich, who compared trance, sensory deprivation, sensory overstimulation with psychedelics and all other techniques to find the common denominator for the state based on psychometric measure, which resulted then in the 5D altered state of consciousness questionnaire. Now, what we have heard yesterday from Charles Raison is that, for instance, therapy-resistant depressed patients, they have a relatively small drop in symptom reductions, also here in the COMPASS study, compared to major depression, which we saw much larger drop even in our recent studies. So the question is, why do different people react very different? So this is really a hardcore question and needs a number of approaches. Just want to summarize a little bit how we think about it. Now, most people think about biological, psychological, social factors have an influence of the psychedelic experience, like in other models of depression or so. But what we found is that the dose in a multiple regression analysis, that the dose is the most important in inducing the intensity of a psychedelic experience. There are certainly a number of setting factors that shape the acute experience. What we found is, for instance, that openness of personality traits helps to go more in an oceanic boundlessness state, or emotion regulation. People that are really trained, like the Buddhist we had studied, open-minded and had a very specific approach to emotion. Opposite to that, we found that people that have problems and suppress emotions go rather in a state with anxiety. So these are factors that are really important. How is the outcome of the acute experience? And certainly the therapeutic model and the patient relationship with the therapist is how is trust built up and so on. But we hardly have enough information about all these shaping factors in addition what the dose is doing. So what would be interesting is to have some basic measures and predict the outcome of the acute psychedelic experience and certainly the symptom reduction. But these are two steps. Many people think that the acute effects have an impact on the acute, post-acute, and persisting changes in behavior. But we are not there. We are really not there. We do hardly understand how the different factors shape the acute experience. But nevertheless, Some people, like Roland Griffiths, came up with the first data showing that the more mystical type of experience you have, the more reduction you have in depressed symptoms. Similar using the 5-ASD questionnaire, Robin Gerhardt's group, Roseman, showed that there is a relationship between oceanic boundlessness, so the positive self-dissolution, and a reduction in depressive symptoms. Now, the complexity is that this measures total score of mystical type experience has a number of items pointing to the experience of unity, ego loss, and on the other hand, positive emotions, sacredness. The same in the oceanic boundlessness scale. In the main scale, when we break it down, we have items for unity, oneness, disembodiment, and again, a number of items going for positive emotion and bliss, in addition to all that space and time. That means we have a huge mix of items or experiences which try have an impact on the acute experience or may then in the end shape symptom reduction. Now, since long we were interested to come up with more cognitive models of self-consciousness. You can read Metzinger's Being No One. It's a really fantastic description of the basic ideas. And within that, these concepts, these neurocognitive concepts, we developed measures for bodily self-experience and emotion processing and regulation. So today I want to a little bit focus on this thing like people call self-dissolution, ego-dissolution, which is very ambiguous, and crunch it down. I try to crunch it down to smaller units. So the promise of neuroscience is that we link manipulations at the receptor site that would say changing the gain, the synaptic gain, which may result, that's the idea, in changes of connectivity between brain regions. So we don't know a lot about microcircuitries. This is, we have heard nicely talks this morning from Christian Löscher and the other one that go into these data. But with neuroimaging, we end up somehow with activation patterns or connectivity patterns. That's what's mostly being used, or we can look in energy measures that relate to changes in connectivity. But we have to keep in mind, everything what we do here is correlational, it's not causal, there's no explanation in the end. But it's really nice to build up heuristic hypotheses how symptoms may relate to neurobiological measures. So most of the studies have been done in resting states. There are about 40 studies, and meta-analysis showed most of them are underpowered. So we need much more data to come up with clear-cut explanations. Now, it has been put forward from Conrad Harris and others based on studies in healthy subjects and depressed patients that the default mode network, which is a cluster of frontal and posterior brain regions like frontomedial, prefrontal cortex, anterior cingulate, posterior cingulate, are important in self-auto-regulation, particularly the posterior cingulate is important for the differentiation between self and others, while frontal regions are more related to self-referential processing. So what we showed very early was that, in fact, the occupancy of 2A receptors in different areas correlated nicely with the experience of oceanic boundlessness. This was frontal regions, anterior cingulate, temporal cortex, which is important for frontotemporal interactions, and the insula, the internal sense of the body. And this has been shown also in recently more sophisticated PET studies, how the occupancy relates to the intensity of oceanic boundlessness. So there is something between receptor occupancy and the experience or a cluster of symptoms. But however, this is very reductionistic thinking. It's just one receptor. It's not what we really think about it. But nevertheless, in a study we have done with Buddhist monks, we found in a meditation retreat that meditated for 4 days, they have been measured before and after psilocybin, there's really a reduction between anterior frontomedial regions and the cingulate and the posterior cingulate. And the more the reduction, the more they were in this oceanic boundlessness state 2 days after the retreat. It's something that endures. And what's maybe the most interesting, 4 months after, they had persistent increased behavioral effects like, for instance, self-acceptance, appreciation of life. Another one I think is interesting is concern with the world. So when we look then at the mediators from the psychological side, we found that, for instance, positive emotions drove appreciation of life, while the feeling of unity is something that is more connected to this disembodiment, or ego loss drives, for instance, concern with others. Just to show here that different experiences may drive different changes. So what we try to come up is something like more sophisticated brain maps. And here we have compared psilocybin versus LSD in 2 studies and looking at global changes in resting state connectivity. And we found over the time, and after drug intake, 20 minutes after 1470, how some regions show hyperconnectivity while others show a decrease in connectivity. That are measures that we hope to understand deeper. This is at the group level, to go more into the single individuum, and maybe we find predictors. What we found here is that the resting state, before they got the drug, predicted how strong the connectivity changes. That may be a simple measure. The day before people go into a psychedelic treatment, making a simple resting state baseline fMRI. When we look deeper in what is driving these changes, then we found, taking gene expression maps, that the 2A receptor was very important, explaining variants. But there was also the 1A inverse negative. So we know from physiology that these receptors have opposite effects. Then they sit on different GABA interneurons, which makes the picture more complex. But there was also some effect of the dopamine system when we put in the dopamine receptors. So I just want to show here, it's not so simple. It's not just 2A and occupancy of a 2A receptor, and that results in symptoms. What symptoms? How specific is that? And how can we measure that? What came out, what Katrin Preller showed in the LSD study as an example, that this feeling of disembodiment or merging with the environment, there are different items in the scale, nicely correlated with the somatosensory motor network disintegration from the rest of the brain. So it makes sense, but it's possibly not yet the whole story. As I told you, the goal would be to have inter-individual reaction patterns to 2 subjects here, that were real data, and we get access to the baseline map, and we put in a number of, from computational science, receptor occupancy or expression maps, numbers, and try to predict how they may react. And from there, we could go then to study how the different doses may normalize this altered pattern. So that's what's going on in the clinic. So just to show here, real data, they use the real PET data to model this gain between excitation and inhibition with a very simple network, and could very nicely modulate and simulate the psychedelic effects by excitatory gain modulation. And this gave very nice maps. The other thing is gene expression maps are standardized. They are not individual maps. But nevertheless, it works quite well. And when we go deeper in here, we always find that changes over the time depend how, for instance, the 1A and the 2A receptor are involved in the explanation of these changes. So it's a very dynamic thing. It's nothing static. That makes it complex. In the end, we've ended up with a very simple extraction of simpler dimensions of the experience, and that was nice. We could very nicely, with high confidence, simulate how a subject, an individual subject, how would the map look when he is in a disembodied state. And that was really the real map we have from that guy and the simulated map. So that is where I want to go a little bit more into this. We talked about the number of receptors involved. We didn't speak about glutamate, the subsequent glutamate release, which may drive these neuroplastic effects. There's a lot of discussion about that. Could you develop drugs that just go into this and skip all that? It's a lot of debate. Is it needed that you have a psychedelic experience, or is this just a transmitter matter? So this is an experience from an experiment with more than 100 artists. They had to draw themselves how they feel when they go through ego dissolution. And you see it goes from the beginning towards dissolution of body shapes, became very peaky here, and then back to normality. One interesting thing is that Hundertwasser, the German artist, was involved in the study. It's a nice publication on that. So, what is the neurocognitive approach to that? Now, Carl Friston, a friend of ours, proposed, based on Helmholtz and others, that the brain may continuously develop a model of the reality. And this is sensory. We can show that through sensory learning. And so there's a hierarchy through the brain. You have the sensory input, goes up the brain, hierarchy comes up in more frontal regions. And from frontal top down, you have make a prediction what comes in. So how stable the world is. So you have a bottom up prediction error flowing up, and the top down prediction at the different hierarchies. What does it mean? It means you expect something when you have learned something. We have priors, we have already some memory at that shape, what's coming in. And if there's a discrepancy or a mismatch between what you predict and what's actually incoming, you produce a bottom-up prediction error. And the whole clue is that this prediction error is continuously updated in the hierarchy and minimized. That's the second important thing. It's not just making a prediction error if there's something that you do not expect. It's all about probabilities. Here you have the priors, your prior experience, the probabilities, for instance, that you go to the zoo and see a monkey. This is the prior probability. Then you really go to the zoo, the monkey is in the cage or is walking around. There are different probability, and it's quite dispersed, quite broad here. The probability distribution that you see this monkey as a real object, but this probability multiplied with the prior, what you have, the belief you have about that you will see him, gives the posterior probability. So that's all based in learning. So you learn sensory input, you have a model, and now the interesting thing is that we can measure these using generative models, but it's the repertoire of perceivable things. It needs a hierarchy, the model, and it needs a widening of the precision. First, I go just into the thing that there is something like a prediction error. So how can we measure that? We do that, for instance, with tactile mismatch paradigms. We administer low pulses and in a row, repeat stimuli. And then you have a deviant, you have double pulses, 3 times, 4 times, 5 times. Here you have a memory trace. People, if you have it 3 times, you expect, the next must be the same stimulus. No, then it drops, so you get surprised, and then you produce a prediction error. So I don't go on all these details, but what's interesting is that we think, and based on neurocognitive models, that the brain is modeling what's the next, and then you have this probability distribution, and you update your prediction. When we do that with tactile stimuli, we see the activation when the brain produces a prediction error between predicted and unpredicted standard, as it is deviant here. We see activations in brain regions that really fits what we think where it should be, in frontal areas, in the, sorry, this is a little small here, in frontal areas, in thalamus, in the insula, and also in posterior areas. Now, when we give psilocybin, in fact, the prediction error is modulated, particularly in frontal areas. These are the most important because they are very robust. So we find an alteration of prediction error. We did in concomitant, we did EEG, and we found the very same over frontal areas. So the induction of mismatch negativity in the EEG fits nicely with the fMRI finding. And now the clue is that the disruption of the mismatch negativity really nicely correlates with this embodiment experience when we rate them. After each thing, we gave them in the scanner already rating scales, and with the feeling of unity. So that means that to be embodied in a body really contributes to this feeling or the sense of ego or the sense of self. This is just post hoc verification through rating scales. But the paradigm is relatively simple and seems to work. We can do out of the scanner really nicely EEG. We don't have to go into the fMRI environment. Now, Friston always pushes, it's not just producing the prediction error, it's the precision, how precise you predict. How, he and Conrad Harris suggested, bottom up, you produce this prediction error in a hierarchical way, and top down, you get a loss of the prediction error, because the precision, how you form, how you come up with this prediction error is changed. And they had a whole story about it, that this loosening of the precision in the end would have a certain equivalent in psychology, being less resistant, and in the end you have belief updating. And their measure was, from EEG measures, some nice things, that the entropy is enhanced. It's very rough, but it's their explanation. So, but nobody has ever studied, is there something with changing predictions at different levels? To come up with this, I don't want to go in these details, but I just want to say we have outcome precision, what you really see when you get a tone or you see a picture, and you have the belief before. That's what Conrad Harris means. You update your belief because the precision that modulates, this is the prediction, very complex thing we can unpack here, that modulates the prediction error. So it's not so much the prediction error alone. Just, we go over that. To do that, we look, for instance, this, you give tones in a row, and this prediction is really precise. So it's the next tone, and the deviant is also precise. But if you give it repeat the stimuli, you have an imprecise prediction. And this is what we are interested in, how precise you can generate a prediction error. To get that, and these are real data, you have to look at each tone. You have to have a model modulating each single tone in terms of prediction error production and precise modulation. So we need a hierarchical model with lower rows where you have the outcome prediction, you have the volatility of the higher order prediction, and this is what goes back into the equation and in your belief what you see. You can do that with EEG. As said, we used here an acoustic paradigm. And now what's the interesting what we found? What we found the first time is that ketamine behaves very differently in modulating the volatility of the prediction error. This is not yet the precision. Ketamine disrupts that while psilocybin increases that. We never saw that so far. And this may explain that we couldn't find deficits in mismatch negativity so far. In earlier studies with psilocybin, we couldn't find this difference because it weighs out over many stimuli. Some stimuli get catched with a very high precision, some with a very low, but over the mean, you think, oh, there's no mismatch negativity. So that's what came out here, and this is really thrilling for us because it's new data, it hasn't been done before, and it opens up a measure that may be linked. Oops. And then if you go deeper into that, we see that placebo versus ketamine or placebo versus psilocybin modulate the belief. So that's really belief updating, how precise you make a prediction, what's next. And if that is changed, your impact of your priors you had before is less modulating what you predict next. So that gives room to change belief system. So that's the first evidence here, experimentally, that psychedelics really may open up the brain on a physiological level. What are the underpinnings of that, whether it's neuroplasticity or this, we don't know yet. And it's hard to test that in human, but it gives the idea that reduced higher level prior precision and increased higher level precision-weighted prediction error expression I would say align with the Rebu model from Carl Harris. So that means psychedelics facilitate the sensitization of higher level priors to bottom-up signals and thereby support belief revision and thus adjustment to the pathological overweighted priors. That's the clue and that's the quintessence of that study. Now, we can go on a little bit deeper and let's just show you the development we do. We thought we can more precisely perturbate the brain, looking at brain networks, distribution over time and space, and take that signature and relate that to the experiences. We did our first study, and you see here you give pulse TMS pulses over a certain area. You do that repeatedly, and you get response patterns. Why do we do that? Because the measure we use is so-called integrated information from Giulio Tononi, and what we see in resting state, the processing, in fact, measured through PCI, which is not just information, it's integrated information. It's a little bit different from the simple LC entropy measures because it's induced, show in fact in different regions increased entropy, but only in resting state. If we put and zap the brain with the TMS pulses, we have not an increased entropy, but the spreading of the network we induce and which we follow nicely correlates with specific properties or dimensions of altered state, like for instance here, blissfulness. So this really, you induce a pulse in the brain during the psychedelic experience, you study the network, you immediately rate what people experience. Just here, you see we give a pulse, there's the baseline, there's the psilocybin, and we really have an online measure over 300 milliseconds can study how is the perturbation, how does the spreading of regions and the involvement of regions relate to different clusters of experiences. So that's the outlook, and thank you very much for your attention. I have to thank a lot Katrin Preller, people involved in this study, John Smallridge and Andrea Casanova, they do the TMS stuff, and Flora Moes does a lot of the calculations, and certainly there are a lot of friends who help to go forward. Thank you very much.
Your friends.